Joanne Taylor from the County Clerk's Office is serving as our clerk today. Will you call the roll, please, on attendance?
Roma.
Yes.
Bill.
Present.
Todd.
Here.
Deb.
Here.
Roy.
Yes.
John.
Here.
Deb.
Yep.
Carl.
Yes.
Trent.
Yes.
Excellent attendance today. Thank you. First item on the agenda is approval of the meeting minutes from February 3rd, and they were emailed to you previously. Motion and a second. Are there any comments or corrections? Ann, if you call the roll, please.
Roma.
Yes.
Todd.
Yes.
Bill.
Yes.
Carl.
Yes.
Roy.
Yes.
Trent.
Yes.
Deb.
Yes.
John.
Yes.
And Deb.
Yes,
Gotta wait your turn.
I know. Your turn is almost up, buddy.
Very
I didn't read them, I just reported on them. Really think.
I say that kindly. Item number 2 on our agenda, local issues in emergency medicine, and I'll ask Dr. Kruger to come forward at this time. Under city ordinance, we're responsible for providing medical oversight within Lincoln and Lancaster County, and Dr. Kruger has served as the medical director of the Emergency Medical Oversight Authority now for almost 4 years. Also in the audience is Kyle Michaelis. He's currently serving as the MSOA board chair. So, Dr. Kruger.
Yes, my name is Jason Kruger. I'm an emergency medicine physician at St. Elizabeth. I serve as the Vice Chief of Staff at St. E's, and I've been the medical director for MSOA since September 2011. We cover Lincoln Fire and Rescue and about 20 other contracting EMS agencies kind of in and around Lincoln. When I first took over the job as medical director, I decided to really get a better understanding of the system. I'd ride along with the guys and men and women and see exactly what they saw as we tried to improve our system. So I started doing ride-alongs with our paramedics, both as shift supervisors and in the back of the ambulance, to really get a good understanding of kind of where our system is and what type of improvements we could make. One of the big changes we initially started with 4 years ago was a revamping of our precepting process as we bring new paramedics into our system certification within Lincoln Fire. Prior to taking over, there was a kind of a mentoring system that could go on for an indefinite amount of time, but we put together kind of a structured system where people would go through either 3 or 4 working sets with a couple of mentors rather than lots of different mentors. We put together an oral board scenarios for them at the end of their precepting process, where we would sit down together and go through some complex cases to make sure that they had the medical decision-making ability to be functioning out on the streets. I would also ride along with our new paramedics in order to really build a kind of an understanding and open communication, where if there was issues or problems or things that they wanted to change to try to improve, that there would be an open line of communication, that they felt comfortable talking to the medical director about where we go and how we get better as a system. The other improvements we've made within our system, we really have taken a look at just evidence-based medicine and put a lot more time and effort into going through research articles to make sure what we're doing really conforms to what the kind of the cutting edge standards are in order to provide the highest level of care possible to our friends, our neighbors, our family members in and around the city. One of the improvements that we've made is we started using CPAP, or continuous positive airway pressure, for patients that have COPD or asthma in order to keep them off a ventilator. There's a number of studies that show they do better with a bridge with that. We tried to improve our documentation with regard to refusals, which is probably any EMS system's highest area of liability, by revamping our forms and really trying to get more documentation and better documentation on people that are refusing service. We've got new devices such as tourniquets and video airway devices, and we probably spent the largest amount of time really implementing high-performance CPR within Lincoln. When I took over, we really began measuring how well we were doing CPR on our out-of-hospital cardiac arrests. two things that have really been shown to improve survival in out-hospital cardiac arrest are high-quality chest compressions and rapid defibrillation. We looked at a percentage of time, how long during a cardiac arrest we were actually on the chest doing chest compressions. National averages, EMS agencies do about 50 to 60% of the time they're on the chest doing chest compressions. They take time to pause, to analyze rhythm, to move patients, to put in advanced airway devices, to put in IVs. When we started, we were probably in the 60s. As of this year to date, our chest compression fraction, or the percentage of time we're on the chest in a cardiac arrest, is 91%. Seattle, which is kind of largely considered to be the best in the world, I was reading their annual report right before I drove over here today. Last year they were at 88%. Year to date we're at 91%. And we are starting to see improvements in survival. With regards to all of our quality improvement measures, we've really looked at things that improve survival. Before I took over as medical director for our EMS Oversight Authority, we'd spend a lot of time in our predecessor agency, EMS Inc., looking at things such as IV success rates, or the percentage of time paramedics get an IV in, which doesn't really correlate to improved survival or improved care. We started looking at things like 911 to balloon times, where when somebody's having a heart attack, how long does it take from the time somebody calls 911 to the time that their blocked arteries opened up in one of our catheterization labs in Lincoln? Seattle, in their prior year report, they had reported their 911 to balloon times for heart attack patients was 95 minutes. In Lincoln, year to date, we're at about 65 minutes, so about a half hour better than the best in the world. I think that's very reassuring for our citizens in and around Lincoln, knowing if they're having chest pain or they're having a heart attack and they pick up the phone and call 911, they're going to have their blocked artery open in 1 hour. That's very impressive, and that kind of data results in better survival and better outcome. The faster you get that artery opened up, the better function their heart's going to have afterwards, the better chance they're going to have of being able to go back to work rather than ending up on disability. We've looked at cardiac arrest survival. One of the things we've done in Lincoln is we were the first and only EMS agency in the state of Nebraska to be accepted to participate into the CARES program. CARES is a cardiac arrest resuscitation to enhance survival. This program started in 2004 out of Emory University as a collaboration between Emory and the CDC. We put forth our application in 2013 and were accepted as, again, the first and only EMS agency in the state of Nebraska to be able to participate in this, so we can measure our cardiac arrest survival and compare it to national numbers and compare it to the best agencies across the country and across the world to make sure that we're providing the highest level of care possible for our patients. Based off of our successful implementation in Lincoln, CARES has invited the entire state of Nebraska to participate, and we're in the process of assisting other cities around Nebraska in enrolling in this and being, I believe, about the 10th state in the country to participate as an entire statewide registry. We have intensely measured things such as our chest compression fraction, Mission Lifeline, which is a partnership between the American Heart Association, the Leona Helmsley Trust, and a number of other charitable partners, has created this program called Mission Lifeline to try to improve heart attack and cardiac resuscitation systems of care. Depending on what city you live in, your chances of surviving a cardiac arrest vary dramatically. If you're in Seattle and you have a sudden cardiac arrest and you're found in a shockable rhythm, your chances of walking out of the hospital are 60%. If that same scenario happens in Detroit, your chances of walking out of the hospital are much less than 1%. It doesn't have to do with better doctors, it doesn't have to do with better paramedics, but it's putting together a system of care that does the best possible things we can for our patients. In 2005, there was a large national survey, and Omaha actually had one of the lowest cardiac arrest survival rates in the country. Within Lincoln, year to date, our numbers are matching Seattle's right now. We are really trying to get out there to be the best and to really provide our patients the highest level of care possible. Mission Lifeline last month awarded out Lincoln Fire and Rescue a silver award for our systems of cardiac care, measuring EKG acquisition in adults with non-traumatic chest pain, and how quickly we're getting people to the cath lab from first medical contact to the time that they have their artery opened up. Lincoln Fire and Rescue is the only EMS agency out of 430 EMS agencies across the country that received an award recognized by Mission Lifeline. We won the silver award. To win the gold, you have to have won the silver once. So next year we hope to be the first agency in Nebraska that is the gold award recipient from Mission Lifeline. I appreciate all your support, and I'd be happy to answer any questions that you have.
Bill?
If Seattle is considered the best, and we beat them, how are we not considered the best?
They've been doing it for a long, long time. We've been doing it for a while, but we want to be there.
Does size matter? I mean, in terms of the fact that Seattle is much larger, obviously.
Seattle King County has a much larger population, but affecting change within organizations, it's a lot easier to do it at a smaller level, and it's a lot easier to kind of rapidly implement change that kind of meets up with kind of the clinical standard of care. So it's looked at on a percentage basis. We're big enough to be nationally recognized. One of the projects that we've just taken on and started in February was we're, I believe, the first EMS agency in the country that is now activating the cath lab pre-hospitalization for anybody that we find in a witness shockable cardiac arrest. If we get on scene and somebody's in VFib or VTAC, they've had a sudden heart attack where they go into a shockable rhythm, our paramedics now are activating the cath lab before we even start transporting the patient to the hospital, with the realization that these people are having heart attacks, they belong in the cath lab. We, in the past, agencies would, try to package these patients up and rush them into the hospital. We've kind of figured out in survival, you got to take the hospital to the patient. We've started implementing a program where we now have a mechanical CPR device where we can do high quality chest compressions in the field, so we have no interruption of chest compressions as we're moving a patient to an ambulance, and we can do just as high quality chest compressions with the mechanical devices we're transporting to the hospital. So with these patients in these shockable cardiac arrests, we're getting them to the cath lab immediately and bypassing the emergency department in some situations in order to try to improve survival.
John and Roy?
Appreciate, Dr. Kruger, what you're talking about on all of the standard we have here in Lincoln. When you talk about cardiac arrest, how many do we experience a year?
We have about 150 out-of-hospital cardiac arrests in Lincoln every year.
I know it used to be like 140.
About 140, 150.
How you mentioned that you went through a lot of statistics there, which
Sorry
are
about
great.
that.
No, that's great. And they're all good statistics with the 90% and all. Out of those 150, how many are we able to save typically?
We're getting approximately, I think, 15 to 20 people out a year. When Seattle and these places come out in the lay press and say we have a 60% survival from out-of-hospital cardiac arrest, they are narrowly looking at witnessed VFib arrests. So if we didn't see somebody go into cardiac arrest, that's not in that specific number, which is one of the reasons why we joined this CARES, this cardiac arrest registry, to enhance survival, so we could actually compare apples to apples and compare numbers correctly. Unwitnessed asystole, I mean, if somebody is not witnessed to go into cardiac arrest and we get on scene and the first rhythm we find is they're in a flat line, their chances of walking out of the hospital alive are close to zero, and that's the same in Seattle. So really looking at these witnessed VFib arrests, which is only about 10 to 15% of our overall out-of-hospital cardiac arrests, but those are the people that we really have a chance to save. Those are kind of the young people that are, out at their kids' sporting event and have this kind of witnessed event. If we can get on scene quickly, which this shockable rhythm, this VFib, doesn't stay forever, it will transition into a flat line if we don't get to somebody quick with a defibrillator. But when we find them in that, we're doing a very good job of getting these people out of the hospital.
If I could just follow up.
Yeah, sure.
I want to get back. I just wondered about the numbers, but I think the key message you're sending is Lincoln has an excellent system, and we should be proud of that, and the way we have it, because the survival rates are good here when you have those really emergent situations. just a clarification, you talked about how you're administering, I think you said CPR like 90% of the time. So is that is that in the cardiac arrest case, or is that in a lot of other assorted calls that you have? Or the
That's looking
firefighters
at
have?
patients in cardiac arrest. So if somebody doesn't have a pulse, the only thing pushing blood through their coronary arteries and pushing blood to their brain is high-quality chest compressions. So looking at the time that they're in cardiac arrest, the percentage of time where we're doing chest compressions year to date is 91%, which puts us up at a very, very elite level. Again, national averages are probably about 50 to 60%, and this does correlate strongly with survival.
Are EMS personnel licensed by the state?
Yes.
And what is the interaction, if any, between the Emergency Medical Oversight Authority and the state licensing board?
We have, in the past, we've had some of our board members that have sat on the state EMS board as well. One of our representatives is from the State Department of Health and Human Services. I just had a meeting last week with the chair of the state EMS committee. So we're in close contact to make sure that we're.
And do you have any direct input onto the continuing medical education coursework and requirements?
I could make suggestions or certainly give thoughts or opinions on that. I don't have any direct
Because it seems
role.
like what's going on here ought to be shared.
We are. We're in discussions with medical directors across the state, trying to get them to do the same things that we're doing. And we've actually had some pretty good discussions with our state EMS medical director, kind of trying to catch him up to here's what we're doing in Lincoln. I had a meeting last month with the medical director and the assistant medical director with Omaha to, again, show them what we're doing in Lincoln as they try to improve their processes to try to get where we are.
Thank you. Mr. Emery and I represent Northwest or North Lincoln constituents and no hospitals in North Lincoln. So talk to us just a little bit about how the equipment, the training that's offered and responding, how that helps in providing quality care for individuals who have maybe a little longer way to go before they get to a hospital.
Right. Look, with regards to patients having heart attacks, that what we want to do is to get their blocked artery opened up as quickly as possible. The biggest rate limiting step in getting that artery opened up has traditionally been in the hospital. How long does it take to get the cath lab to the hospital, the interventional cardiologist, the cath lab team? Several years ago, I believe in 2008, 2009, we started doing and transmitting EKGs from the field. When I was in residency in the early 2000s, we couldn't, the emergency department couldn't even activate the cath lab. If we would do an EKG on somebody and they're having a heart attack, we would have to wait for the cardiologist to come in, look at the EKG, look at the patient, and then the patient wasn't having a heart attack until the cardiologist said they were having a heart attack. We've moved that up to where emergency medicine physicians can activate the cath lab to now where paramedics are activating the cath lab while we're still on scene before we even start transporting the patient to the hospital. So since I've taken over in 2011, it has become a standard where as soon as we get an EKG, our goal is within 5 minutes on scene, we'll get an EKG on a patient having chest pain, transmit that to the hospital, and if the patient is identified as having a heart attack, we're activating the cath lab from the field so that by the time we package the patient up, get them in the back of the ambulance and drive towards the hospital, hopefully they will never stop in the emergency department. They will go directly to the cath lab where our door-to-balloon times in the city across the hospitals has been outstanding. With regards to cardiac arrest, we really are trying to take the hospital to the patient. In the field, I mean, we can put in advanced airways, we can do high-quality chest compressions, we can give every medication in the field that we can give in the hospital. The only added benefit here with this recent introduction of mechanical CPR devices, these patients that are in a refractory shockable rhythm where they're getting shocked more than 5 or 10 times, there are some case reports now of people walking out of the hospital alive by going to the cath lab and getting their blocked artery opened up to get out of that shockable rhythm. And we had our we've had 2 cases now in Lincoln where we've taken people to the cath lab while one of our mechanical devices is going in place. One of them got a return to spontaneous circulation, got a pulse back immediately after that blocked artery was opened up, which in the past is somebody that we would have terminated a resuscitation in the emergency department in the field, and now we're getting pulses back on these people.
I tell you what, this is just most impressive. You know, the military has a term called the golden hour, and this is like with battlefield casualties. If they are taken care of within that first hour, or if medical treatment can be given, their chances of survival are very greatly increased. You certainly have made a golden hour. So thank you for that. Do you have an SOP? You certainly must have an SOP that details how you do this. Is this something, you know, that you could pass out to other organizations or other counties?
Yeah, we've been discussing with agencies across the state our protocols and how we've implemented this. Yes.
Could you address the protocols? We talk about when somebody calls the 911 center, that the person taking the call goes through a list of protocols, try to find out exactly what the emergency is. Could you share with what developments you've experienced or perhaps implemented in recent years?
With regards to our 911 dispatchers, they initially, when we took over, had used a flip card set, a card index, and would kind of go through those in order to identify what type of response a person needed, how sick they were, based off of what the caller was saying. Since then, we've gone to a computerized priority dispatch, and very recently, we've started a quality assurance, quality improvement program where we're actually measuring with some of these calls, like our cardiac arrest calls, the percentage of time that our dispatchers are able to recognize that somebody's in cardiac arrest, the time it takes from the time, you know, the call comes in to the time we're able to dispatch somebody on these critical calls, and also looking at how long it takes from 911 call to first chest compression with regards to our dispatcher-assisted CPR. They've done some studies with regards to community education for CPR. You have to train anywhere from like 1,000 to 10,000 lay people to get one person who will do chest compressions in and out of hospital cardiac arrest. So you put in a huge investment of training, which is a good thing for a community, but you got to train a lot of people to get one person who'll do it. Where we're again in the beginning stages of putting together this kind of comprehensive program with our 911 dispatchers, who continually field calls where people are in cardiac arrest, and really focus on training them to try to improve our numbers with regards to how quickly we're giving CPR instructions and how quickly we're getting hands on the chest. One example, the question, you know, if you have somebody calling in, do you know CPR, is not a good question, because people are like, no, hold on, I don't think I do. Where, okay, we're going to have you get down down on your knees by the patient's side, you know, put your hands on their chest, and you start delivering chest compressions. I'll count this out for you, rather than giving somebody a way to opt out.
You said a couple times, you've used the term taking the hospital to the patient.
Yes.
And so I'm assuming that one of the barriers to implementing this type of project in other cities is the unwillingness from in this case, the hospital, to cooperate with the EMS. Can you kind of explain how you were able to be so successful? Because I mean, I think that's really one of the keys to this whole program.
The nice thing about our EMS Oversight Board is we have representatives from both hospital groups that are involved in this decision making, and Lincoln is blessed with 2 outstanding cardiology groups. Sometimes competition's a good thing, because these people obviously they want to do the best for their patient, but in this kind of era of competition, as soon as one group says, yeah, we're willing to do this, the other group is right there as well. It really wanted to be on the cutting edge, where we're trying to do absolutely everything we can for our patients. So working with the 2 hospital groups, the 2 cardiology groups, we've had a lot of success in coming together in a collaborative way of really focusing on patients and trying to do the best thing we can for them. certainly in other systems where there's even more hospital systems and more cardiology groups, it is hard to get them to sit down and come up with a standardized way of, here's how we're going to do, treat this disease process. Where in Lincoln, being a little bit smaller, kind of back to the comments on Seattle, it makes it a little bit easier for us to implement change.
Final question. You've talked a lot about the city of Lincoln. Of course, that's where 90% of our population is, but you've done a great job reaching out to our rural volunteer squads as well. Could you just talk about that briefly in closing?
Shortly after taking over the EMS Oversight Authority medical director spot, I started going out to our county EMS agencies. And one of the first places I went to, I stood up and gave a lecture, and one of the guys got up in the back of the room and said, I've been on this service since 1982, and I've never even seen a medical director before. Thanks for coming out. I make it out to every one of our agencies every year, so that obviously they know who I am. If they have questions, we're on the same page. So part of it is getting out there. We've been able to do some innovative things with regards to our cardiac care. We've got a number of our county agencies that are now doing EKGs in the field from out in the county. They're able to transmit those to Lincoln Fire, our paramedics, before we even get on scene. We can tell whether a patient's having a heart attack and have the ability to activate the cath lab before Lincoln Fire is even on scene and met up with the patient. So that's been something the state has invested some resources in, and we've partnered with them in order to, again, try to do the best thing we possibly can for our patients.
Thank you very much. It was certainly informative, and the whole system is something that we all take great pride in. Thank you for being here.
Thank you very much.
Item number 3, severe weather exercise report. Carrie Egan coordinated this exercise for this building, and I'm going to ask James David Saver, our City County Emergency Manager, to join us as well should there be any questions in addition to the exercise that was conducted in this building.
Good afternoon. Everyone should have received a copy of the severe weather exercise final report and recommendations. It's a number of pages. I won't go through the entire report, especially since county board members, some have heard it twice if you're on the building commission, and I think John has heard the report. So I'll try to just center on the recommendations that came out of the report. I'll just give a brief description of the exercise as well. Back on March 25th of this year, the National Weather Service conducted a statewide severe weather exercise. The exercise consisted of a tornado watch being issued at 10 a.m., then followed at 10:10 a.m. With a severe weather warning for a tornado. We participated in the exercise by doing a modified shelter in place for the county city building. We worked with the mayor's office and especially Bob Nemechek from personnel, who's the safety and training officer for the city, to help design the exercise and coordinate it for the entire county city building. Got pretty good participation in it, and we had a number of takeaways from the exercise. We thought originally of doing a full everybody in the building shelter in place, and decided because of liability questions, disruption of operations, and the lack of notice that we had, which was about 2 weeks, that we would want to defer that, and maybe in the future, I know Roma would very much like for the building to do a shelter in place exercise where anyone in the building is moved to one of the designated shelters, but we can talk about that later. So on to the recommendations that came out of our report. The first one is in the area of weather notifications for employees. What we found, and what Jim has known for years and years, is that the NOAA radio, the NOAA, or the National Oceanic and Atmospheric Agency radio, is the best means of receiving notification of severe weather. We have one in the offices of the City Council and County Board, and perhaps you've heard it go off at times. It's hard to miss. But those are the real-time warnings that are going to tell you, give you the most accurate, up-to-date, instant information that you can get from the Weather Service. Some of the larger departments probably need more than one of these because not everybody can hear them in the larger departments because of their little cubby holes and carols and offices in remote places. So that was the first thing we determined on how best to notify the employees. We used to have a desktop computer alert system, but the software for that apparently has gone south. I know that Information Services is working on replacing that, so that's another system. Not everybody has a computer, but many, many, many employees in the building do have computers, so that's an additional redundancy that we would recommend. Another one is to research and recommend a smartphone application for severe weather alerts. Jim has done a little bit on this already, and we'd have some cautions in that area that there are a number of different applications, and we might want to recommend only a few to make sure that employees are getting the relevant and accurate information. A second recommendation is that we're recommending that each department develop its own standard operating procedures for how they respond to severe weather warnings. Not all departments are the same. They all have different needs. Our treasurer's office, for instance, has a lot of cash laying around. You don't want to just walk out and leave cash drawers open to the public, and so they are developing the one. And now, actually, that recommendation was made by former Chief Deputy Sheriff Bill Jarrett, who realized in the drill that he didn't have an SOP for that, which was about the only thing in the world he didn't have an SOP for, but now he's going to have one for severe weather as well. And we think there needs to be regular review and updates to the SOPs for each department, and we should we should post emergency response procedures for the visiting public in conspicuous places throughout the building, and also for the benefit of the employees. You may have noticed throughout the building that we have designated areas for shelters, and what the notification consists of a little green sign that says shelter, and I've actually had people standing under the shelter sign saying, "Where's the shelter?" So they're really not very conspicuous. So we're going to recommend better signage. Bob Nemechek had a creative idea on this. He would go over and poach a few of those Iowa State Cyclone signs that you get from their bookstore or something, and then we could post those, cut off the Iowa State, and then post those outside to call it a storm room, which would be a whole lot more visible than a small green shelter sign. As part of the process too, we, and it's mostly Bob Nemechek, we reviewed the physical adequacy of all the designated shelters and made some changes based on that review. What Bob found is that a number of the shelters have windows and doors, or no doors, just open doorways, and probably weren't the best shelters. So attached to your report, you have, I think it's Exhibit B, which was the original shelter designations, and then we've modified them, and that would be attachment C. So that's for all 3 floors of the county city building. Another big recommendation, and we've already talked to the building commission about this, is to establish a designated shelter under K Street in the which leads to the K Street parking lot. The portion right under K Street would be an ideal shelter location. It's right under the street. It's about as solid as you can get, but for the fact that the south entryway to that portion of the tunnel is open, and along the rest of the tunnel there's a plexiglass skylight, which could be a bad scenario, creating a wind tunnel effect for anybody that was in there from a severe storm. As Jim has pointed out to me, it is located on the northeast side, which is more favorable because most of our storms approach from the southwest. But regardless, that is a dangerous situation. We would recommend that to replace another previously designated shelter, which is the hallway in the basement, which we totally recommend against. It's lined with windows next to a garage, which is open to the west. Could probably be one of the worst places you could possibly be in a tornado situation actually hitting the building. So we would not recommend anyone go to that location. In fact, that was one of the takeaways from the Hallam tornado. When the tornado hit Norris School, their original plan called for putting the kids in their big long hallway because there were no windows and they could shut it off. If they had done that, there would have been multiple fatalities and multiple injuries because the whole building was destroyed, and that whole tunnel was turned into a wind tunnel, or that hallway was turned into a wind tunnel with flying debris at hundreds of miles an hour. So fortunately, we learned that lesson without having anybody in the way of that. We've recommended to the building commission that they do install a storm-resistant doors on the south side of that area on K Street, which might require some ventilation improvements as well. And I've talked with Don Kling just today, and he is working on that, having John Kay from Sinclair Hilly prepare some cost estimates. So unfortunately, it wouldn't be free. There would be some cost involved, but that would be the absolute best shelter that we could provide for this building. Don Kling is also looking at the signage. We did, if you move down to number 4 on our list of requests, I did ask for a legal opinion from the Lancaster County Attorney's Office. Christy Bauer finished the opinion back on tax day, April 15th, I see there on the date. And generally our concerns were, what is the extent of our affirmative duty to provide tornado shelter for visitors in our building, or shelter from severe weather, and also what is our liability if someone is injured in one of the shelters that we provide. We were worried about the second question because of the inadequacy of some of our shelters, and we're worried that we put somebody into a room that's not really adequate as a shelter and they're injured, or do we have liability? It's the opinion of the county attorney. I asked him to share it with the city attorney. I'm not sure if your office got a copy or not, but I can make that available if not. That generally government does not have a duty, or at least local government, counties, cities, does not have an affirmative duty to provide notice of severe weather. And there's a lot of case law on that. So as affirmative duty to either provide notice or provide shelter, there just is no affirmative duty, which forms the basis of your tort liability and your negligence liability. So starting with no affirmative duty, it's extended to that if someone is injured in our building in one of our shelters, since we do not have a duty to provide shelter, it's very unlikely that someone would be successful filing a negligence action against us because they were injured by severe weather in one of the shelters that we're providing. We had some concerns in that from the architect originally that FEMA, and they originally told me it was state law, but there's nothing in state law, but FEMA has standards for tornado shelters, and they're very thorough, but that only applies if you're receiving money from FEMA to upgrade your facility. So if we have facilities that don't meet the FEMA standard, it does not provide a basis of liability to city or a county government. So with that opinion, Don Kling is moving forward to look at potential signage changes and other changes to the designated shelters. Our final recommendation was to get this information in front of the Building Commission and the City County Common. So here we are today. So I'd be happy to answer any questions.
Thank you. Been working on possible safe spaces in West Lincoln, where close to the trailer parks, and in working with NEMA, they have informed us that what we're talking about is not shelters. That shelters are places where people go to stay after a tornado has destroyed their homes. But a safe room is what we're talking about for where to go in the midst of
Yes, and
situations.
That was one of our concerns with asking the legal liability question, is that we're not following the FEMA standards, the FEMA nomenclature, and is that going to create liability for us? But I'm sorry I interrupted. Do you have a further question on that?
Just that I think it probably is best for us to use that terminology of safe room rather than shelters.
Yeah. And we're looking at that, and that's we were worried about using the word shelter if it really wasn't a shelter, or if we use safe room and it's really not a safe room under NEMA standards. But I think with our liability concerns being alleviated a little bit, I think we do have some more flexibility. So I think whatever gets the best attention of the public is what we should use.
And I think that brings up a good point. We want to offer as much protection as possible. And that's one thing I've had an opportunity to fielded some questions and did some site visits before and after this drill in late March. A lot of times I find we give credit to the employees. It's their workspace. That's where they spend the most of their time. I can walk through and make some suggestions that if severe weather is approaching, you may want to do this, you may want to do that, but defer to them to be as safe as possible. Obviously, the best case scenario would be to have that, impenetrable fortress that's certified as a safe room. If that's not available, what's the best we can do? So again, it's one of those things, give those employees that ownership, that responsibility. Danger is approaching, do what you have to do to keep yourself, your coworkers, any member of the general public that may be there, offer them that opportunity to be as safe as possible.
Oh, I should add one additional twist to the legal opinion, because there's always some bad news with the good news. Workers' compensation creates an entirely different question for liability. And under present standards of the Nebraska Supreme Court, it's very likely that if an employee is injured in a shelter during bad weather, that we would be liable under workers' compensation. In fact, anywhere in the building, if they were injured under the present standards, we would be liable for workers' compensation.
Any additional questions for Hal?
Carrie, I know that this was primarily focused on the county city building, but can you kind of mention about the other properties owned by the county? I know that we've got the crisis center, we've got the health department, the jail. I mean, I know that, can you briefly mention just?
Well, of course, this exercise didn't include those properties, but that would be a concern that we would have as well. We got a number of the engineer shops out and around the county, the engineering building out in 444 Cherry Creek, and county extension buildings, ours, Trabert Hall, the crisis center, all those are our buildings. And we probably would want to expand, from a county to ask those departments or building managers to do some planning with regard to shelters and operating procedures as well. So it's not just this building. That's a good point.
Yeah, and just generally speaking, that's just it. It's not only those facilities, but workers who may be out in the field. How do we communicate with them to give them notice that severe weather is approaching? The technology is there to give us that advance notice as it works from a watch to a warning. We can track the speed, the direction of it. So if we have employees out there, whether they're at their assigned facilities or they're out in the field, again, that early notice so they can plan accordingly. And I think that falls to each of the departments, each of the supervisors. How can you best manage and supervise your employees to make sure that they are as safe as they can be at all times? So I think this exercise was a very good first step. And the fact that it brings up these questions, these discussion, shows that we definitely, when I say we, I mean primarily me, have some work to do in this area. But again, it's a very good starting point in moving forward. That's just it. I see it as the first step in the process.
Any additional questions? Gentlemen, thank you very much.
We're gonna tag team.
Okay.
And just so that you know, happy to tell you the health department did do that exercise, and we do all of ours. We do both tornado and fire drills. So some of you have actually had the fun of being in our building when that happened. So thanks to you guys for reminding us to do that all the time. We're going to tag team and
Sure.
All right, my friend. I'm Judy Halstead, Lincoln Lancaster County Health Department, and I think Jamie's got our information up. Just really briefly, the information that I'm going to present to you today is dealing with the community piece. Chief Pashong and possibly even Jeff Kirkpatrick, as city attorney, are going to talk about what activities the law enforcement and the city attorney's staff did. I'm going to talk just a little bit about the health concerns and what's happened with K2. As you'll see, the information that's incorporated into this presentation involves information that's provided not only from the health department, but also Roger Bonine from LFR, Brian Jackson from LPD, Joe Wright from Lincoln Public Schools, Jeff Blymeister from the Sheriff's Office, Phil Tegler from the Bridge, Pam Randall at St. E's, Dr. Ed Malenik at Bryan, Sarah Hoyle from Human Services helped distribute information. Susie Blue reached out to us to help enforce further at Matt Talbot because LFR had a number of calls at Matt Talbot. And then other community partners and of course all of our staff. We got involved, the health department got involved because the state law requires that emergency hospital departments report to local health authorities when they see either clusters of health concerns, they see what something might look like an outbreak or anything unusual. And Bryan Health reported this to us at about 10:38 on Tuesday night, the 21st, that they had seen a number of cases in the emergency department related to K2 overdoses, and they were very concerned about what was happening. Anecdotally, I had also had communication with LFR's battalion chief who said that EMS was really frustrated at the number of K2 overdoses that were happening. And a number of folks were obviously, it was all popping. LPD was getting a number of cases that they were reporting, and it was all happening in the community about the same time, particularly from the 15th, 16th, 17th is really, Friday the 17th is when folks were really noticing that we were potentially having a pattern, and then over that weekend. We had a community agency meeting of all of those folks that were listed at Bryan Hospital on the 23rd, and at that point Brian Jackson said, feel free to share our morning briefing media event Friday morning, which is what we did, to try and get information out. We've also gotten information out to community agencies. LPS sent information out to families on Monday the 27th. And then the community agencies are continuing to review and enforce policy related to substances. Many of them have policies against controlled substances or alcohol. But they've always run into this problem with K2 because it could be considered an incense, et cetera. But a number of the community agencies have kind of stepped up their policies and are considering that a substance that they do not want on their properties. I'm going to pass around just really quickly a data form that you'll have an opportunity to review. This is information that we asked the 3 hospitals that have emergency departments and the bridge. We'll just go both ways. And the bridge. Most of you know the bridge is formerly Cornhusker Place, is typically receiving patients. They also received patients during this same time, and Phil Tegler also provided information. I'm going to speak to some compiled data then that we did. We went back and asked those facilities to provide information to us about the individuals that they saw. So the 3 hospitals in the bridge helped provide this information in addition to LPD, LSO, LFR, and then Lincoln Public Schools. This is our best guess at our estimated unduplicated. And you have to keep in mind what happened is LFR may have presented. You're going to hear from Jim on some data related to Lincoln Fire and Rescue's known cases. But what happened when we were hearing from the hospitals is the individual might have been unresponsive when Lincoln Fire and Rescue responded. They picked up the patient, took the patient to the hospital. Or they may not have admitted their K2 use, but then when they were really sick in the hospital, and the hospital saying, what did you take? The hospital was getting more information. So I'll give you some updated numbers over the weekend. This only goes through the 30th. Chief Pashang will talk about on the 23rd what LPD's involvement was. And then also talk about what's happened since then with letters from the city attorney's office. But you'll see that on the 23rd was when LPD took an enforcement action, and then the news conference was on Friday the 24th, and then we saw our numbers dwindle dramatically, in part because of the work that LPD, or in large part because of the work that LPD did on getting the source out of town. So what do we know about the calls? We know LFR had during that time known or suspected calls. Again, we talk suspected because Lincoln Fire and Rescue knows they had 60 for sure calls, but when we compared with the Bryan Health data, we know that those came in as potentially known or suspected cases. Lincoln Police Department responded to 43 calls known or suspected. Lancaster County Sheriff's Office responded to 2 known calls. There was an overlap in many of those calls. Again, they're suspected cases because they're often not verified until hospital treatment. And then in addition, other substances are used at the same time. We know, for example, there was a DUI, but the person also used K2. So there's a number of those co-occurring events that are happening. One of the things that we wanted to make sure that everyone knew is people are thinking these are young people using this substance. Really, only 11% of this number were of those individuals who were minors. The vast majority of them are adults. The average age was the age of 32. And not all calls that LPD responded to resulted in transport. Only about a quarter of them. Pardon me?
Runways, right? You can't fix stupid.
Well, we got a lot of adults that are using this stuff, I'll tell you. Yep. You got it. 7 of the 8 cases at the bridge during this 2-week period were not transported to the hospital. Only 1 of them was transported. The bridge kept the other 7, but all of them were admitted by law enforcement. 2 of the cases responded to by Lancaster Sheriff's Office in their jurisdiction. Those were both transported to the hospital by Lincoln Fire and Rescue via mutual aid. And then 1 suspected case was reported by Lincoln Public Schools and transported by LFR. We've had 9 frequent flyers, as I'm referring to them, and those would be individuals who had 2 or more calls in that 2-week period. We had Lincoln Police Department and Lincoln Fire and Rescue shared 2 of those individuals So both responded, both agencies responded, and both times for those 2 individuals. Lincoln Police Department had one, what I refer to as frequent flyer, that LFR did not treat at all. So LFR didn't go on either one of those calls that LPD had. LPD had one additional frequent flyer, so they saw them twice, and LFR only saw them once of those. But then LFR had 9 frequent flyers themselves, so 5 additional individuals that they saw twice during that 2-week period that they responded to, and none of those 5 did LPD respond to. So we've got folks that not only are using this stuff, and I'm talking about these are folks that went and were involved in some type of interaction with LPD. Most of the ones that LFR were involved with were transported. So obviously we have significant issues with those folks who they didn't get it the first time. So Doug, here's your cue.
I rest my case.
So current information, St. E's has not had any cases since 4/24. Lancaster Sheriff's Office has not had any cases since 4/24. The Bridge has had no cases since 4/24, and that was confirmed this morning. Now, I will tell you, we had good news at 8 o'clock this morning where Dr. Malinik shared that they had 0 cases over the weekend from 7 p.m. till 7 a.m. until we got another note that said, day shift said, no, we've had 4 cases on May 2nd and 2 cases on May 3rd. So we still have activity. We know that obviously we're not, we're getting it out of Lincoln. That's a good thing, but we're all not naive enough to know that there's other stuff coming into town and that will happen. Obviously, we don't know yet if what happened in Lincoln was some bad K2. We don't know if there was another chemical that was sprayed on that K2 that made folks sick. We know that very often K2 is sprayed with chemicals. There may have been a bad chemical. We're pursuing through some other avenues, trying to look at what may have been the chemical compound of some of the samples that we have. And if we get information that's conclusive back, we will share that with you. But what we're trying to do is continue surveillance in the community. Through that form that you have, the hospitals and the Bridge are continuing to provide information. And they're obviously not giving us names. You can see that. They're not giving us names of individuals. They're not giving us their address. As much as law enforcement would love to say, what is the product, where was it sold, and when was the last time used, you need to understand from a health perspective, they're treating that patient. They don't necessarily care what the brand of the product was or where they bought it. They care when it was last used, but they may not be providing all of that information. And in fact, the information we have back very often said patient refused to say where that information was purchased, where that K2 was purchased. We want to continue to work with policymakers. I don't believe there's any redeeming quality to K2. If you want incense, you can go buy it a heck of a lot cheaper at other places in town. We don't believe there's any redeeming quality, and we believe it's potentially very, very dangerous. Many of you know that in Lancaster County about 1.5 years ago, there was a young man who did die from an overdose. We did not have any deaths related to these patients, but we did have an individual who did code, and we had a number of them that were intubated or required assistance in breathing when they were in the hospital. So we want to continue to work with policymakers to keep it out of Lincoln. We also want to continue to get the word out about the hazards of K2, fact sheets, information through school. And then in addition, you'll be seeing this coming in the next few days, hopefully. Excuse me. This is great, isn't it? Jamie. Pardon me?
Hi, I'm Dr. Ed Malinik.
Here, let's try
and
this.
Here's what you need to know about K2.
Ed Malinik,
K2 is a
and here's what you
dangerous
need to know about K2. K2 is a dangerous synthetic drug that is sending thousands to emergency rooms nationwide. It's often contaminated with unknown toxic ingredients, which makes its result unpredictable and even deadly. Ingesting K2 can result in a rapid heart rate, high blood pressure, vomiting, seizures, and even coma. Stay safe, stay away from K2. Find out more at lincoln.ne.gov, keyword K2.
That we've been talking about, but the biggest effect of why we've seen this reduction over the last week has been the work of Lincoln Police Department and also Jeff Kirkpatrick. And Jeff, do you want to just come up? Because they may have questions of you.
Thank you.
And then we can probably do questions at the end for everybody if we could.
Well, I can talk briefly a little bit about the investigation. There's some things that I
can't wind up talking about. There's been multiple agencies that have been involved in investigating the K2 in our community for a year and a half. Some of the problems that we encounter is our state statute is pretty cumbersome in regards to being able to give us the tools to effectively deal with this. It's on one vein, it's a legal product if you use it for a potpourri and incense, but if you smoke it, it can have some pretty dramatic health effects. Around April 17th is when we started to get some medical emergencies calls on overdose and things of that nature with some of our citizens here. And then the weekend of April 18th and 19th, we received a telephone call from the Sioux City Police Department indicating that they had a high school senior who had died as a result of ingesting some K2. And some of their preliminary interviews with another individual that was with this high school senior at the time indicated that they had come to Lincoln and that they had purchased the K2 in Lincoln, and they were wondering if we were experiencing any deaths at that particular point in time. About that time, this young lady's father indicated that she would no longer talk with the police and cooperate with the investigation, so their investigation kind of ended at that particular point in time. Last Wednesday, we had a meeting with the U.S. Attorney's Office, several federal agencies, our narcotics task force, as well as we had invited the Sioux City detectives down that had been investigating on that particular death. They indicated that there were 4 individuals that had come to Lincoln, bought the K2. Once they got back to Sioux City, they had lit up some of the K2, and within a matter of passing this pipe around between those 4 people, the first one who had smoked the K2 was already dead. Indicated that during the autopsy that it appeared as though the individual had just hemorrhaged to death on the inside. This has been an issue that we've been trying to fight and deal with for, like I said, a year and a half. Used to be dirt cheap down at 27th and Randolph. We'd actually go down there and watch individuals go into dirt cheap and purchase the product, go diagonally across the street to the park at 27th and Randolph Northwest corner there, and these individuals would light up the product and start smoking it. Unfortunately, it's an open area. By the time we could run up there and try to make some kind of an arrest, everything would be scattered to the wind, and we really wouldn't have any product in order to be able to prosecute these individuals. I think that there's a little bit of maybe a disconnect between law enforcement and the legislators. They feel that they have given law enforcement the tools to adequately be able to investigate and prosecute these crimes. I understand that Senator Chris has indicated that maybe he's going to put together a group to study this particular issue this summer. In my mind, that will be great, because I'm not sure that the left hand knows what the right hand is doing at this particular point in time, and we really do need to wind up getting law enforcement, the prosecutors' offices, and state senators together so we can have a good dialogue in regards to what the problems and the issues are. Although it still is a real tough case to wind up investigating on these, because the chemist, the minute that a law gets passed that these particular types of chemicals can't be on this potpourri, then the chemists wind up changing the chemicals that they lace this potpourri with. And so state legislators all around the country are constantly fighting this battle in regards to, is it illegal or isn't it illegal? Our current statute that we have is that we have to wind up showing that some of these products have an effect against the receptors of the brain. And a lot of that research hasn't ultimately been done, and so that becomes real problematic. And so we need to wind up having some good dialogue and some good conversation in order to wind up helping us more effectively deal with this. We did serve a search warrant last week, what was that, the 23rd, on a couple of the places. We seized over 12,000 pipes and associated paraphernalia, as well as about 1,200 packages of K2. We took everything off the shelf that we could possibly take off. And then we've been continuing to monitor these places ever since then to ensure that new product hasn't come in and has been placed on the shelf. So right now, we're not aware of it being sold, but you know, there still could be some product that some people still have in the community, or you can potentially go out on the internet and order the product and get it that way as well. So it is kind of a little bit of a battle, but you know, there's better minds out there than me on how to ultimately wind up getting some laws passed to be able to wind up dealing with this. In the city of Lincoln, we had a death associated with this April 3rd of last year out on West O, and the autopsy did come back indicating that K2 was the cause of death on that. And Judy had already talked about the one that the county had already had. So we've been pretty lucky as a community that we haven't experienced the number of deaths that some communities have around the country. But this recent trend that's been going on, we're not the only community that's been experiencing this. I'm aware of, I think it was Alabama, New York, a lot of other states have also been experiencing a rash of some adverse effects by this K2 here lately. So with that, I'll let Jeff talk.
Tell me questions,
Oh,
and then we'll
okay.
have Jeff make his comments, and then we'll go to questions. We've got about 5 more minutes.
Okay, I'll keep it quick. We were looking in the law department about what we could do to, as kind of an adjunct. This was after the press conference talking about the ill effects and after what the police department had done, and started looking around the country at what other communities had done. And found an example in Arizona that was apparently fairly successful, and it was attacking the retailers from the standpoint from it being a public nuisance selling K2. And we feel comfortable that we can't guarantee that a judge would agree, but certainly we think we have a very strong case if we can locate a retailer in Lincoln that's selling K2, that we would take them to court, try to get a court order, an injunction, ordering them not to sell K2. So the first step that we took last week was to send letters to all of the retailers that we had identified, or LPD had identified in the community that had been selling K2 in the recent past, letting them know that we were contemplating this step and asking them if they would sign a voluntary agreement not to sell K2. And so far, all of the retailers we've heard from have agreed, at least agreed orally, not to sell it. We don't have any that have turned in signed agreements yet, but we'll be reaching out to them in the next few weeks. We won't be suing anybody unless from this day forward we find out they're selling K2, but we're doing the legal groundwork, so we're prepared if someone new opens up a operation or someone goes back on their word and starts selling it. We'll be ready.
On this product, is this something that an individual needs to overtly ingest as opposed to possibly having a third party contaminate something else? I'm just trying to think of our citizens here to fully understand how this can occur.
And our experience from looking at the health reports, and Chief Pichon can clarify, but the majority of these health effects have been related to individuals who have smoked it. We do know it can be added to teas. We do know it can be added to foods. That may happen more inadvertently, but certainly the vast majority of the cases that I have from the hospitals, those individuals ingested it via smoking it.
Thank you.
Other questions? Director Cassidy, is there anything you'd like to add? Well, I know that, and maybe the council's had some of this information before, but it certainly is informative to the members of the board, and we appreciate the partnership between LPD and Sheriff's Office and the City Attorney and the County Attorney. We do have the County Attorney Joe Kelly sitting in the back of the room, so we appreciate those partnerships and addressing this public concern head on.
The only thing I wanted to add, if I could, is just to give kudos particularly to Lincoln Fire and Rescue and to the hospital staffs. They have really worked their tails off. I mean, yes, Chief's right, this has been in the community, but it's been in this last 13 days that we have really seen the onslaught of these folks having these really significant negative health effects, and they really have been bombarded. So if you have the opportunity to thank those folks, LPD has as well, but LFR had about 3 times as many cases, and the hospitals had walk-ins and a number of other things. So if you have the opportunity to thank those folks, please do.
Thank you very much. Is there any other information or items to come before this board?
Move adjournment.
If not, I want to take the opportunity to thank Mr. Emery for his service. I gave him a hard time earlier, but he has served the city and this board with great honor and distinction, and you would be missed. Send that same message to Jonathan Cook, and wish our 2 candidates here the best of luck tomorrow. Nobody knows better than the people sitting around this table the challenges of running for elected office. So with that, we'll remind everyone to vote tomorrow and wish you the best of luck. So motion to adjourn?
Second.
John
And I-
was over here.
I
All
made
in
the
favor,
second.
say aye.
Aye.
We stand adjourned. Thank you.
Somebody said put anhydrous